Welcome, everyone. My name is Ryan on One Central, living at St. Joseph Medical Center here in Bellingham. I'm also a member of our house-wide Professional Development Council. I'm pleased and excited to introduce today's session. This is our second session in the free virtual health equity 6-part series. On behalf of the Professional Development Council, we are so glad you're here with us today. I invite you to close any other programs and closely listen in to what our speakers have to share in the next 90 minutes. They are incredibly talented individuals and even more astounding together. Prepare to open your minds and shift the way you interact and care for individuals with substance use disorder. Before we get started, a few housekeeping items. This session is recorded and will be available to all registered participants once completed today. There will be opportunities to ask questions and interact within the presentation. In the meantime, please keep your audio muted and camera. Use the chat at any time to ask questions or to make comments, and periodically we'll ask the presenters those questions. A big thanks to North Sound ACH and Tiffany for this virtual platform that we're using today and for her support today. And nursing continuing education credits are available after the session is completed. So keep an eye in your email for the link. Today we have with us several team members from Cascade Medical Advantage. Natalie Andrews, a perinatal nurse, Eric Harry, a counselor, and Dr. Adam Cartman, a provider. Together, these individuals, along with many other team members, work to treat and support individuals with substance use disorders. And yeah, I'll let Natalie take it from here.
Hi, everybody. Thank you, Ryan. So in my role as a nurse, I work specifically with pregnant and postpartum women with substance use disorders. So that will be the lens in which my presentation is focused on, but it also applies to most populations. And additionally, I'd just like to say that I could easily do a 2-hour presentation on the information that's coming up. So this is just a brief introduction to the topic. Do you mind moving it one more, Tiffany? Sorry. Thank you. So we'll start with talking about childhood trauma. So childhood trauma and substance use disorders are closely linked. In the 90s, CDC with Kaiser conducted a landmark study called the ACEs study, or the Adverse Childhood Experiences study. And this looked at 3 overarching categories of childhood trauma that fell under abuse, which is physical, emotional, or sexual, neglect, physical or emotional neglect, and then household dysfunction, which encompasses parent with a mental illness, incarcerated relative, mother treated violently, divorce, and substance use. They found that through that study and then subsequent studies, about 60% of Americans have experienced at least one of these childhood traumas. Women are more likely to have experienced 4 or more, with 15.2% of women surveyed versus 9.2% of men. And I circled substance use on there because that's kind of where my role focuses. And I work with pregnant women who are have histories or active substance use to help connect them with resources, build strong communities of support and recovery. And as a community, it's really important that we invest in families, and this starts with investing in our pregnant patients. So we can't count them out from the start. People do recover, and we can help them with that. So this graphic is looking at those who have experienced 4 or more of those adverse childhood experiences versus people who have experienced none of them. And I think some of the data on here is pretty shocking. If you see at the very bottom there in purple, so someone with 4 or more ACEs is 30 times more likely to attempt suicide in their life. And next to that in red, 10 times more likely to have problem drug use in their life. And I think what's also really interesting is this expands into other areas, like if you see the gray area, physical health. So heart disease, diabetes, they see that it actually increases those as well. And further research has really found that stressful events and toxic environments affect children's neurodevelopment, cognitive function, and ability to cope. And as you can see, can have lasting impacts on their health and well-being. And so the goal is to interrupt the generational cycle through appropriate treatment, support, and intervention. And but that being said, not everybody who experiences trauma as a child will, have these effects later in life, and that's due to what we call protective factors. So looking at these things like connections to other non-parental adults, close friendships, school safety, neighborhood safety, these are all protective against the effects of childhood trauma. So fostering community is key to breaking the generational cycle of trauma. And we can't talk about women's health and substance use without also talking about racial inequities. So many of you probably remember the media hysteria around crack babies in the 1980s, where the media demonized and dehumanized primarily Black women who used crack cocaine while pregnant. And we saw disproportionate sentencing laws where they were 100 times harsher for crack cocaine versus powder cocaine. So that disproportionately affected Black communities. And in thinking back to those ACEs, one of them is a relative who is in prison. So this kind of increased the ACE score for a generation of children through mass incarceration. And this led to distrust of the judicial system and the healthcare system. And research has shown that hysteria was unfounded and that poverty was a more powerful influence on the outcome of children than exposure to cocaine. So I just like to bring that up, especially in comparison to the opioid epidemic, which affects more white people and has been looked at as more of a public health issue, which is the right way to look at it. That's how we want, this to be treated, but it's just important to compare that to how the crack cocaine epidemic was treated in the 80s. Okay, and also I just want to acknowledge that as we are on the land of the Lummi, Nooksack, Swinomish, and Upper Skagit people, it's important to acknowledge the impact of historical trauma as well. Current psychosocial issues have to be viewed within the framework of historical trauma that is carried across generations. And these two diagrams kind of show, that there's increased rates of PTSD, mental health diagnoses. And then the diagram on the right is, I think, pretty shocking, looking at violence against American Indian and Alaskan Native women. 84% have experienced violence in their lifetime. They're murdered at a rate 10 times higher than the national average. And 96% of rapes are perpetrated by non-Native men. I just think these are very important things for us to be aware of. Next. And then Dr. Blackstock talked about this in depth in her presentation, but I just want to briefly revisit this. So this graph is looking at pregnancy-related mortality rates for white women versus American Indian or Alaska Native women versus Black women. And if you look at this, American Indian and Alaska Native women are 2.5 times more likely to die related to pregnancy, and Black women over 3 times as likely. And I think something else that came out of this that was pretty shocking was that this goes up to 5 times more likely when you look at Black women with a college degree versus white women with similar education level. And usually we see these numbers and disparities shrink with education level, and it actually increases. So it's important to know that these exist and work towards eliminating them, because numbers like this can't be acceptable to us. In my work, I hear a lot of, but she's pregnant, why won't she just stop using? So we're going to kind of dive into a little bit about why this is more complicated than that. Um, Although motivation to stop is higher when someone is pregnant, um, it still is complicated. So we're going to look into that in the next few slides. Among women who have a substance use disorder, they're 4.5 times more likely to also have a mental health diagnosis, often untreated or undertreated. 80% of women seeking treatment report a history of sexual assault, physical assault, or both. And more than half of women with substance use disorders report recent intimate partner violence. And then this is all compounded with homelessness, poverty, lack of resources, and support. So the key is really to continue to engage with clients and welcome them back into care without judgment. And again, just to kind of summarize the complexity of trauma and substance use. So trauma and chronic stress change how the brain develops. This impacts attention, decision-making, learning, and response to stress. And then oftentimes people may turn to substances to relieve the feelings of anxiety that develop around trauma. And then long-term substance use changes how your brain functions. So leading to impulsivity, poor self-regulation, changes to the reward system in your brain. So, and then that kind of leads to being unable to stop even in the presence of negative consequences. And so basically bottom line is it's really complicated. It can't be reduced down to just choice. There's a lot at play. And Dr. Cartman's going to discuss more about brain changes later on today. So we kind of want to, talk about how do we break these cycles of trauma and how do we assist patients in achieving their life goals in terms of my patient population to parent their children. Looking at a big kind of overarching system level, we break it down into prevention. We're talking pediatricians, school support, safe neighborhoods. Early intervention, if somebody is at risk for substance use, we're looking at universal screening, early referral to resources. And then treatment looks like medication, so methadone, buprenorphine. For pregnant women, there are specific programs in our state that are 6-month inpatient programs for families to go to as well. So those are incredibly helpful. But I think what a lot of us here are wondering is, what can we do in our day-to-day work to improve outcomes for patients with histories of trauma and with substance use disorders? It feels really overwhelming. And a lot of us don't, even sometimes I don't feel like I have all the training for this. So, but we know that building trusting relationships improves outcomes. So if we can commit to being trauma aware and engaging with patients in a way that doesn't re-traumatize them, that's a huge first step. And, it's true, we can't heal someone's trauma in one hospital encounter or one doctor's visit. And we aren't trauma specialists. I'm not a trauma specialist. Long-term trauma and substance use disorders can heal through counseling, treatment, building strong communities of support, medications, mental health services. But individual interactions like that we may all have with clients that are, if they can have positive interactions, those cumulatively improve their self-worth and can begin to heal. And sometimes patients don't have a safe place to turn in their lives. So we as the healthcare system need to be a safe place for them to go. And unfortunately, I think for a lot of patients with substance use disorders, their past experiences in the healthcare system have shown them that they can't necessarily trust the healthcare system. And for example, if a patient goes to their first OB appointment and they've perceived that they're being judged, they may not go back and receive prenatal care. So there's a saying that trauma is a thief and it takes your safety, your trust, your hope, your connection, your security. So when we're looking at a trauma-informed approach, we're kind of looking at how can we provide those things back to patients. And so the guiding principles, so all of our interactions with patients, no matter how small, should kind of follow these guiding principles of safety, trustworthiness and transparency, peer support, collaboration and mutuality, empowerment, voice and choice, and cultural, historical, and gender issues. In order to kind of be trauma aware and know how to work with patients that have experienced trauma, it's important to kind of step into their shoes and understand what the patient experience might be like. First of all, stigma is very prevalent in our society, and many patients have really low self-worth, and they're aware of how society views them and talks about them, and they internalize that stigma. In terms of judgment, I always kind of think that patients are their own harshest critic. They don't need us to pile on top of that. And oftentimes a patient may come to our care already primed to feel judged by, from us. They're based on their past experiences, they're assuming we're going to judge them. So they may be thinking, that one nurse was so rude to me the last time, you probably will be too, which may lead someone to present as kind of guarded, and we may perceive that as defensive. Shame and guilt is a vicious cycle. A lot of times patients have a lot of shame about their substance use, especially pregnant women. But then it's really hard to sit with that feeling of shame. It's uncomfortable. They don't know how to sit with that. So they turn back to the substance to relieve that feeling of shame, and it just builds on this cycle. Trauma we've talked about, and then I think it's really important to kind of dive in a little bit about ambivalence. So anytime any of us make a change in our life, we are giving something up, and it can be really small, like I want to save money, but I like to eat out, and it's kind of a give and take. And sorry, next slide. So if we can understand the meaning of the substance for somebody, it really helps us to understand why somebody may be ambivalent about stopping their use. So substance serves a purpose in someone's life at one point, but obviously the use of that is harmful and it becomes very detrimental to their life over time. And we're not by any means advocating the use of substances, but sometimes stepping into someone's shoes and understanding what that substance meant to them helps us to avoid villainizing it. And we can kind of understand why a client may be ambivalent about stopping their use. And most often a substance is a tool people use to feel better. That's the simplest way to put it. And most who use substances will tell you they don't enjoy it anymore. But when you make that step to give up a substance once and for all, it means giving up something that maybe has brought you comfort, helped you cope, and now you're facing the world without that, and it can be really scary, and a lot of suppressed emotions and traumas come back to the surface. So I just invite you guys, if you want to in the chat box, just share some reasons why somebody might use a substance. Again, we're not advocating the use of substances, but just what might that bring to somebody's life, and why might they use a substance? And then we'll just kind of call some of them out. Yeah, these are great. Anxiety, numbing, comforting, stress reduction for fun or to escape, social anxiety, physical pain. I can't keep up with all of them. This is great, you guys. Yeah, these are, peers are doing it, belonging. Yeah, these are really great. I think something that has stuck with me is, I don't know if anybody's read the book In the Realm of Hungry Ghosts, but by Gabor Mate, but someone in the book says that heroin feels like a warm hug. And that's always kind of stuck with me. And yeah, you guys touched on a lot of things. One that I think sometimes isn't as common, or that people don't think about right away, is I have a lot of women I work with who use methamphetamine to stay awake if they're homeless because they don't want to be victimized. So if they're sleeping outside or if they're in an unsafe situation, they may use methamphetamine so that they don't fall asleep at night and open themselves up possibly to being victimized. Wonderful. Next slide. Okay, so in working with patients with substance use disorders, the language that we use is really important. We want to use non-stigmatizing person-first language. The way we talk about a patient equals the way we think about a patient. And so we want to talk about patients using appropriate language. Avoiding things like addict, junkie, druggie, meth head. Instead, saying things like a person with a substance use disorder. That's the person first language. And that applies to medical things too. It's not like that diabetic, the person with diabetes. And that being said, sometimes you'll hear patients call themselves a junkie, but a lot of times that is kind of rooted in deep-seated shame and poor self or low self-worth. So we don't want to perpetuate that. Again, ex-addict, instead history of substance use disorder or person in recovery. Clean or dirty drug screen, those are really common. You hear that a lot. And it kind of turns into a patient like I'm clean or I'm dirty, but using just really factual language, presence of opiates in the urine or presence of amphetamines in the urine. And non-compliant is one that sometimes we see in like nurses' chart notes or things like that, but that carries a little bit of judgment with it and doesn't respect the fact that clients can, or that patients can decline certain aspects of care. So declined kind of respects the fact that patients do have that right. And then addicted baby and drug baby, those, you don't hear those very often anymore, but I just like to include that. Addiction has certain behavioral aspects that a baby is just not capable of, especially one that's just born. So born physically dependent on opiates is the appropriate language. And, just don't talk to patients using this terminology, but also don't talk to colleagues using this terminology. Patients can overhear conversations like that, and it can be really stigmatizing. So in looking at and talking about re-traumatization in the healthcare setting. So re-traumatization is almost exclusively unintentional. I don't know anybody who would intentionally re-traumatize a patient, but that doesn't make it harmless. So we do want to be aware of ways in which the way that we give care, which is probably the typical way that we give care, can actually re-traumatize patients who've experienced trauma. So I'm looking at specifically an OB setting, but feel free to add things in the chat box that are other ways that don't have to be unique to women's health, that someone could be re-traumatized. But in women's health, having your body exposed, loss of control, especially I'm thinking labor and delivery. Once that process starts, there's no stopping it, and that lack of control can feel really scary. Painful procedures and experiences, potential CPS involvement, especially if someone was involved in the system themselves or has had past experience with CPS. And then having a male provider on call. I mean, of course, all of our male providers in women's health are very sensitive to that. But for a patient, that can be a little bit hard. And of course, we don't have a choice. That's the way the system works, but just being really aware of that. And ways to kind of combat this, always ask permission to touch a patient. If a patient declines something, try not to place any judgment on that. It usually doesn't mean they're trying to be difficult. There's usually something more behind it. Have a plan ahead of time if the patient wants you to stop, like a cervical check, just, have a plan. Like if you say the word stop, I will stop immediately. Asking questions, is there anything else I can do to make you more comfortable? Explaining procedures, what they might be like, what they might feel like, approximate timing, and just knowing also in OB that, like I said, there's a loss of control that you feel, so knowledge is power. So really just sharing with patients what to expect. Okay, so I really like this graphic because it also grants grace to the healthcare provider. So in terms of setting boundaries, protecting yourself, not taking on more than you can or should. So I just like to point out a few of these, like predictability is really important with clients who've experienced trauma. Surprises generally don't go over well. Knowing what to expect is really helpful. Under the category space, giving patients a little bit more space and time to recover if they've had if they've gotten upset or had an outburst, they might need more time to kind of regulate their emotions. And choice down at the bottom there on the right hand side. So choices really give a voice, give patients back a voice, and make them feel empowered in their own care. So I think going back to, what can we do just in our day-to-day care to help patients with trauma and patients who may have substance use disorders, and really focusing on building trust and building rapport. And these things on here are going to seem really basic, but they actually go a long way in building rapport. So greet the patient, introduce yourself and your role. I think we all, me included, think that we do this. And sometimes I think that either I don't have the patient's full attention when I introduce myself, and just really making sure the patient is able to hear you when you introduce yourself. Committing to sit, so kind of pull up a chair at the side of the bed. It's really helpful at the beginning of your shift. Just pull up a chair. It eliminates a power differential, and you can kind of talk to the patient about the plan for the day. Slowing down, listening, looking patients in the eye. Thanking patients for their honesty if they share personal information with you. The number one thing is probably managing expectations. So that goes back to patients feel powerless in the hospital. They feel like they have no control. And so information is power. Anything you can provide the patient, any information is really helpful. That includes like for example, say the doctor orders lab work. Let the patient know ahead of time, not at the moment the lab is going to be drawn. It just gives them time. If someone has used IV drugs, that can be really triggering. Just gives them a minute to kind of know that's coming, instead of it just, coming in and we're drawing this lab right now. And be aware of body language. Rushing around can be kind of viewed as a judgment or a reflection on their self-worth. Even though that's not our intention, and we're trained as nurses to multitask, but taking a few minutes to just give full attention to a patient can go a long way. And then just a few more: celebrate successes, point out successes, no matter how small you perceive them to be. Patients with substance use disorders are not used to hearing their strengths or positive things about them pointed out. So that kind of goes with the second one. Just maintain a strength-based lens and call out those strengths when you see them. Empower and offer choices whenever you can. It doesn't have to be a huge choice. It can, if you're able to give a medication now or if in an hour, ask them what they prefer. Educate rather than scold. And use open-ended questions. So what's most important for you today? Or what are your goals for the day? Just really give them a voice in their care. So that being said, of course, challenging behaviors, challenging interactions do arise. And just kind of understanding that trauma responses do flare at times of change and stress. And so being in the hospital is incredibly stressful. Becoming a mom is incredibly stressful. So especially for the women that I work with, this can be a time where trauma responses do come out to the forefront. Behaviors are not personal. When we as caregivers take them personally, that's where communication can break down. And it can be really hard not to take them personally. I mean, these things are, if somebody's being verbally abusive or things like that, it's really hard not to take that personally. Behaviors that we find challenging may have once been adaptive or protective. So maybe somebody shuts down when they're overwhelmed, or there's aggression or defensiveness, and that may have been protective for them in the past, but it's not helpful. It's not helping them now, but that may be what they know. And then be careful not to label a traumatic stress reaction as someone's personality. And this can happen a lot through like handoff or sign out, where it kind of carries through as labeling a person a certain way. And we don't want a bad day held against us forever. So we just want to give our patients that same grace. And it's always helpful to just think what's the underlying need behind the behavior. And sometimes we have no idea. Sometimes that's really hard to figure out. Just a brief scenario, a lot of times we run into situations where a patient wants to go outside to smoke, and that is against the policy. And it's really easy to, and I've definitely done this before, to just be like, sorry, that's against the policy. But taking just a minute to kind of acknowledge the loss of control they're experiencing. So something like, it's really hard to be in the hospital and feel like you have no control over anything. Make somebody feel heard. And let them know what you can offer, whether it be, talking to the doctor about a nicotine patch or something like that. And then as nurses, I can speak for myself, I like to make moments educational, but this is not a good time to discuss health risks of smoking. Okay, and we all bring, as caregivers, our own trauma and our own past experiences. And we may have family or friends with substance use disorders. So we bring that to the table when caring for patients, which can really impact how we interact with patients and the impact they have on us. So burnout and compassion fatigue are very, very common. It can happen quickly when you're working with patients with poor emotional regulation, poor coping skills. I'm also a bedside nurse in a different role. So I understand that when you have a heavy, if there's a heavy patient assignment and one patient is really taking up a lot of your time with disruptive behaviors, or their visitors are unruly, that can be really, really stressful. And it's okay to feel triggered or activated by a patient's behavior. That's normal. And we're all human, so not every interaction will go well. We really advocate for a team approach where debrief situations that go really well, debrief situations that don't go well. We can learn from both of them. Ask for support from your team. The CMA team is also available for support or to help with situations. So I'm going to just switch gears and finish up with just looking at an evidence-based trauma-informed approach to treating neonatal opiate withdrawal syndrome. So a baby born physically dependent on opiates. And this is called the Eat, Sleep, and Console model. So this was implemented, it'll be 6 months tomorrow here at Peace Health in Bellingham. And this is a model of care that's rooted in empowering moms. It's family-centered, really promotes the mom-baby dyad, and kind of follows the tenet that mom is the baby's best medicine. And essentially, moms with substance use disorders are given the same opportunity as others to bond with their baby in those early days. And just kind of, I'll just go over the fundamentals and kind of compare it to the old model. It's 3 function-based questions addressed every 4 hours. So these are looking at, is the baby feeding normally or well? Is the baby able to sleep more than 1 hour at a time? And can the baby be consoled within 10 minutes of crying? So the old model, which was Finnegan scoring, was a 21-item assessment every 4 hours that tended to be more subjective and was a little bit more disruptive to the baby in the sense that the baby had to be unswaddled, unwrapped, a lot of kind of poking and prodding. So this one can just be done with baby in mom's arms. It's a minimum 96-hour observation period of baby where baby rooms in with mom and a support person. And of course, this is if baby's medically stable in other regards and if mom is able to participate. The old model, the baby was in a nursery or NICU setting, and mom would visit and assist with care. And in this model, mom is really expected to do all of the care. And this new model really allows the mom and the bedside nurse to collaborate more closely as well. And then the old model relied on morphine treatment, which oftentimes if a baby got a dose of morphine, they were looking at probably a 2 or 3 week hospital stay with a long titration of morphine, usually, it could be 80 doses. And this new model allows for morphine, PRN, or as needed. So morphine's available if the baby's really struggling, but they may just need 1 or 2 doses to kind of get over the hump, and that's it. It doesn't put them on this titration of needing 80 doses of it. And the real focus is maximizing non-pharmacological intervention. So that we're looking at swaddles, swaying, swings, lots of skin to skin, low stimulation. And that's kind of where mom is the baby's best medicine for a huge focus on skin to skin and breastfeeding. And then this model uses a team huddle to develop the plan of care. And this really gives mom a voice and empowers her. And she's kind of seen as the most important member of the team. All right, so early results, I don't have the numbers, unfortunately, but we're seeing a greatly decreased length of stay for babies, decreased number of morphine doses, strong postpartum support for moms, and moms who are feeling more confident and empowered. And the longer stay for mom where she's able to room in is allowing us to set her up with more resources and support. Lactation is able to visit with mom daily. And postpartum is a really vulnerable time, especially for those in recovery. The lack of sleep, the isolation, hormonal changes really increase their vulnerability at that time. So setting them up and having them feel more empowered when they leave the hospital is really important. And I just want to call out the whole team in the Childbirth Center in Bellingham, who this started 6 months ago, and it's been going really well. And then I just kind of included my 3 guiding principles that I keep in mind when I'm working with patients, especially if I'm feeling a little bit emotionally charged or triggered by some behaviors or interactions. And those are: people cope the best way they know how, people are more than their substance use, and people make sense in the context of their story. And then I leave you with homework. So for those of you who work directly with patients, try using a strength-based approach. So leading with strengths when giving a handoff or sign-out report. A lot of times we lead with the negative, or, oh, this patient is so difficult, or those kinds of things. Try to kind of reframe that and lead with the strengths. And then focus on using person-first language and other non-stigmatizing language in your notes, handoff reports, and everyday interactions. And that's it. Thank you guys for having me. And I think my email will come up. If you do have questions that come up after this, feel free to email me.
Excellent. Are there any questions for Natalie? That was really interesting. Thank you so much for sharing. All right, if there's no questions, we can move on to our next speaker, Eric Harry.
Okay, now you can probably hear me. Good evening, everybody. Thank you for everybody who's responsible for putting this together, and of course the participants for being with us. I want to give you a little bit of a warning. There's a little bit of redundancy here. Actually, there's quite a bit of redundancy, and it's on purpose. And that's because, ACEs, is a tool that is used to look sort of longitudinally from birth all the way through adulthood. And so my presentation is going to focus on 5 different areas: ACEs, different types of trauma, treatment approaches to trauma and co-occurring disorders, trauma-informed care itself, And then the American Society of Addiction Medicine has 6 dimensions that we as counselors use to measure an individual's aptitude for change or any barriers there might be there. So feel free to, next slide, please. Okay, so adverse childhood experiences as a clinical and public health issue, right? So certainly our endemic essentially can be concentrated in certain areas such as socioeconomically depressed environments and so on, highly interrelated, have a commutative effect. And the effects of ACEs or adverse childhood experiences certainly are biologically plausible. We can see this manifest in multiple ways, and we'll get into that as we move forward here. Next slide. So here we're going to look at adverse childhood experiences as a national health issue, right? So it has a strong influence on adolescent, reproductive, and mental health, smoking, alcohol, and illicit drug use. And I should probably put in there also abuse or misuse of illicit drugs, right? Prescribed medication, risky sexual behavior, risk of re-victimization, risk of re-victimization, and then stability of relationships and homelessness. Next slide. So here we continue to look at it as a national health issue, right? So ACEs increase the risk of heart, liver, and chronic lung disease. We see higher rates of HIV/AIDS and STDs and other risks for leading causes of death. So this is a very powerful slide. So this is per 100,000. And so we can see the correlation, it's directly, ACEs score is directly proportional to the use of licit or illicit drug use. As you can see on the left, we're looking at something like 12 per 100,000 individuals ever having a drug problem with an ACEs score of higher, greater to or equal to 5. Ever addicted to drugs, right? Up in there in the 8 to 10 area. Think about this particular last number here, ever injected drugs. Think about what it might take for you to inject drugs in order to treat your discomfort. That's coming in at around 4 per 100,000. That may seem like a really low number, but it's actually a really high number. Okay, so we spoke about drug use. We're going to look at ACEs and its relationship to smoking and lung disease, more manifestations of health adversities in regards to ACEs score. So with a score of 4 more, we're looking at early smoking somewhere in the neighborhood of about 12 per 100,000. Currently smoking is all the way up there in the 18 per 100,000, which unfortunately leads to ongoing respiratory issues like COPD, which is very common at around 8 per 100,000. Adverse childhood experiences is a bit of a summary. It's very common, so common that I think we don't catch it. There's strong predictors of health risks and disease from adolescence to adulthood. And these unaddressed combinations make ACEs measurements one of the leading, if not the leading determinant of health and social well-being of our nation. So really powerful. So most of us are familiar with Maslow's hierarchy of needs. If you look down at the bottom left there, you'll see conception with an arrow pointing up to death. And so this is kind of an inverse look at what Maslow's hierarchy of needs would look like in terms of a higher ACEs score. So the higher the ACEs score, the more significant adverse effects we're going to have, right? So on the bottom, we see the ACEs score, and then we see social and emotional and cognitive impairment. We're seeing adoption of health risk behaviors such as substance use. we're seeing an inability to sort of regulate behaviors, and that leads on into early deaths. So, right, so we're going to change the page just a little bit, move away from ACEs. Understand that ACEs is definitely in the background here. What we're going to do is focus more in on types of trauma. So in particular, we're going to look at these 5 different types: PTSD, simple or single incident trauma, complex or repetitive trauma, developmental trauma, intergenerational, and historical trauma. So let's start with PTSD. Simple or single incident trauma exposure could be a car accident. We're going to experience intrusive symptoms, right? Certainly going to have the prevalence of behaviors such as avoidance, negative alterations in cognition or mood, inability to regulate in any given situation, plus or minus continuity of thoughts. So you can think of that in terms of mania, right? Inability to handle any particular situation. Moving into complex or repetitive trauma, trauma that reoccurs repetitively over time. Classic example, of course, is physical, sexual, or emotional abuse, physical and emotional neglect, being in war, being a refugee, victim of human trafficking, experiencing captivity, or chronic verbal abuse, just a wide range. Okay, so developmental trauma certainly is complex in terms of disorder in children. It's the same as complex trauma, except worse since trauma occurs during development. And so adverse childhood experiences and the way they manifest up into adulthood are issues specifically looked at via the ACEs lens. So an extremely useful tool. Intergenerational trauma, we're going to take a bit of a look at this, a couple of slides anyways. Dysfunctional family transmission, aunts, uncles, brothers, sisters, mothers, fathers, passing down to one another. Victims of complex childhood trauma are at a higher risk of becoming parents that pass on the trauma to a new generation, right? So where does it start? Where does it stop? It tends to keep going the higher the ACEs score. Sexual abuse victims are more likely to abuse children as adults. A further view into intergenerational trauma, epigenetic genetic transmission. Here's a really interesting fact here that proteins on stress genes have been detected as passed from traumatized Holocaust survivors to their children. So known to manifest in multiple generations ongoing, 3 and 4 generations deep. So it's felt that any severely traumatized individual has the potential to pass epigenetic changes from preconception trauma to their offspring. So historical trauma. So right, the picture on the left kind of tells the story. Absolutely tells the story. Colonial injury, right? Taking an individual out of their known environment and trying to drastically change things. This is just, this is historical trauma. Collective experience, we can think of the isms, namely racism and others. Certainly a cumulative effect across generations, cross-generational impacts. It just tends to keep going without addressing it or treating it. And then cultural genocide, right? Acts to destroy nations. Okay, so we're going to change the page a little bit here. Trauma treatment. And so we're going to look at repairing emotional trauma safely. The key word there is really safely. So treating trauma, right? So how can we foster engagement in patients? And do feel free to add anything into the chat box here. How can we foster engagement in patients who feel hopeless, inadequate, unsafe, and have a natural tendency to mistrust? I'm sure there's a number of things that are rolling through your minds at this moment regarding that question. So some of the ways that we can answer that is we want to promote dignity. We want to show respect. Trust and safety in a therapeutic healing environment is just pivotal to treating trauma. We want to design treatment modalities, therapeutic relationships, and accommodations to meet the patient's needs, okay? We are the providers. We need to make sure, as Natalie put it, sitting with the patient, we need to make sure that we're listening and we're understanding the story the best to our ability in order to meet what the patient's needs are, right? So we want to reflect recovery and person-centered principles. And we want to reflect patient satisfaction, engagement, and self-empowerment via the therapeutic relationship. So this is the Hamilton Depression Score scale. This is a really interesting graphic here. Basically what we had is we had 311, forgive me, I'm having a hard time saying that, but 311 participants in this. And what we had, it was the red reflects the ACEs, childhood trauma, and then the green reflects chronic depression with childhood trauma. And so, you know, we can see that antidepressants as a standalone is a fine intervention. We can also see that for psychotherapy. What we certainly want to highlight is the combination of the two. And this reminds me of medicated assisted treatment, which is what we're doing often here at Cascade Medical Advantage in our patients at the hospital. And I think Dr. Carbon will certainly get in more of that in a little bit. Okay, so treating trauma continued, right? See, these are some modalities, EMDR, eye movement desensitization, and reprocessing. Mindfulness, a huge one, right? Attention to and awareness of the present moment and non-judgmental acceptance, right? So that's not only for just the provider or the patient, that's for both. We want to make sure that we're non-judgmental and we're willing to accept the situation for where it's at that moment. Trauma-focused cognitive behavioral therapy, attachment-based therapy, and exposure therapy. And so as Natalie so eloquently put it, we're not trained to treat trauma in these ways per se. We can certainly have open client-centered dialogue with our patients bedside. But what we really want to do is we really want to help connect the individual to a therapist that is trained in trauma-informed or focused care. Trauma-informed care, what does it look like? Okay, so again, feel free to add to the chat box if you'd like. What do you think that looks like? Well, labeling patients feeds hopelessness and reinforces negative self-image. Obviously not a level of care we want to be known to provide. Asking a patient about their childhood is sending a powerful message about you care, right? Again, speaks to sitting with a patient and hearing their story. Paraphrasing and the like are just phenomenal tools, motivational interviewing, and all the above, right? So we want to educate patients that unconditional positive regard is important to their health. And so this is one area where we'll use the word educating, right? We want to stay away from that word. And sometimes it feels quite threatening to a patient, but unconditional positive regard, you know, it's one's ability to, you know, accept themselves and care for themselves and build a relationship with themselves. And so we certainly want to educate folks on how that's accomplished. And I need to call out Dr. Gargano for this next statement. He says, his approach is do not ask. Do not ask what's wrong with you. Rather, change the dialogue. What happened to you? You know, the idea is, you know, these conversations build trust and help gain rapport. We want to invite a dialogue that allows us into their lives. We're going to have a really hard time with, you know, patient navigation, service connections, and so on, and just making the patient feel worthy of themselves if we're not building rapport. So what happened to you as opposed to what's wrong with you, certainly a good point. Trauma-informed care in the hospital. So this is largely what Natalie and myself are doing these days. We're blessed to be able to be a part of it. And so as Natalie said too, I'll just sort of mirror, as I said, we're going to sort of overlap here, ask open-ended questions, right? What is your idea of a better life? How do you see me being of help to you on that? What are your goals? Always ask for consent. We don't want to assume that somebody's just willing to just allow us to share this information. Take the time to explain yourself, explain what the idea is of, you know, getting well, and ask them if that's what they'd like to do. Speak in a calm voice, certainly is validating. Certainly do not assume. We do not want to assume that an individual is just simply using, you know, some illicit substance to get high. You know, the idea is, in my experience, most of the individuals that I'm working with are using it to treat discomfort. So we really need to learn what's going on by not assuming. Avoid false reassurances is a big one. We may have an individual in the hospital for, say, 5 to 8 days. We do not want to sit there and say, we can get you housing, okay? This is not a fact. We're unable to do so. We certainly don't want to, you know, approach, you know, a mother that has just given birth and saying, you know, CPS is not going to be involved. These are not truths, right? We don't know this for sure. So we really want to avoid reassuring things that we're unaware of. And then teach relaxation by example, right? That can be done in multiple ways, breathing exercises, just having an open dialogue with one another. Revealing some of your own story is just fine. A conversation about the weather, whatever seems relaxing. Okay, so going to change the page entirely on you folks. The American Society of Addiction Medicine has an assessment, and in that assessment, there are 6 dimensions that we use to sort of take a snapshot of a person's life, see where they're at now, and kind of where they've been and even where they would like to go. So it really invites dialogue, and it allows us to learn a lot about how we can provide better care. So dimension 1, we're going to go through these dimensions together. Dimension 1 is acute intoxication and or withdrawal potential, right? So a means of measuring last use, an opportunity to measure physical observation of substance use, side effects such as uncontrolled psychomotor agitation, right? Withdrawal symptoms, potential barriers to interventions, benzodiazepines. I'm sure Dr. Cartman may get into that a little later. Dimension 2, we look at the biomedical conditions, right? Examples could be MRSA, could be active abscesses. This gives us an indication, are we using, is the patient using currently? We'd certainly like to look at an historical snapshot if we can. Is there a history of endocarditis or hepatitis C? Is the individual pregnant or not? How many kids do they have? Is there a prevalence of HIV or AIDS in and around them? Do they have a PCP or not? Next slide. Dimension 3 really looks at the mental health piece, right? Emotional, behavioral, and cognitive complications. You see the word complications because what we're doing here is we're measuring aptitude not only for wellness, but we're measuring barriers. We want to know if there's a barrier present that prevents one from going to treatment or from getting the level of care that they're interested in engaging in. So we want to identify barriers to care. We want to look and see what mental illness looks like for this individual. Is there a prevalence of or a history of? We certainly want to look at the effects of use upon your mental health status. And we always want to check in regarding suicidal ideation or homicidal ideation. Dimension 4. Okay, so this is where it gets a little involved. Dimension 4 is readiness to change. And so what we use is the trans-theoretical model, the stages of change. This is a well-known model with 5 different stages, and we're going to go through these fairly quickly here. Feel free to ask questions in the chat or email me later if you'd like. But I also want to make sure that you understand that these are not in chronological order. A lot of times, yes, when I'm first meeting a patient, they are in pre-contemplative stage, right? There is no action towards change at that point. They could be at a contemplative state of change. There could be thoughts or awareness of need for change, but lacking action. A person or a patient could certainly be at a preparation stage of change, right? Could have essentially, they're aware of the need and they would like to make a change. And at this point, they're looking to gather tools. They may be working with another one, like a counselor or, a mental health counselor to gather tools for help. Continuing the action stage of change, right? So this is working a program of recovery, right? We're now in action. We're developing coping strategies and bolstering interpersonal skills, working with others to elicit change, right? That's a big deal. Natalie spoke about guilt and shame. Individuals are quite withdrawn in early phases of recovery. And so, when you're reaching, stages of like action, when you're actually developing, interpersonal skills and working with others, you're reaching a really nice plateau in terms of your recovery. Dimension 4 continues with the maintenance and recovery stage, right? So we want to, let's see here, we've learned to avoid triggers. We're now celebrating and recognizing progress, reinforcing recovery goals, and continuing to work with support teams or sponsors or others in your life. Dimension 5, relapse and continued use potential, right? So as I said, these stages aren't necessarily in chronological order. An individual could certainly backpedal a little bit. And so, Dimension 5 kind of does this check-in. What is a relapse or continued use potential look like? What are the skills that a person has gained? Do they have sober supports in their life, right? Does the patient have sober supports? Is the patient willing to engage in medicated assisted treatment services, such as Suboxone, Vivitrol, or Methadone, plus counseling? And Dr. Karpman, I'm sure, will discuss more about that. And does the patient have a history of sobriety? A really important angle, right? Were the skills once on board? Is it something that we can, through dialogue and gaining rapport, build upon and re-elicit those skills in order to use for future sobriety means? So Dimension 6 is our last dimension. It looks at our recovery environment. Does the patient have housing? Is the patient living with others that are still using substances? Does the patient engage in self-support, right? That's a really big one. AA, NA, CA, church, etc. Does the patient have employment even? And what is the patient's ethnicity or cultural background, and does it support sobriety, right? So that kind of covers the 6 dimensions. And so there's a couple of things I want to leave you with. Language. Natalie spoke about language, rephrasing words that aren't harmful or labeling, right? So we are blessed at St. Joe's at Peace Health in the system. We no longer treat junkies or addicts. We treat individuals who may need support. And it's perfectly logical for individuals to be treating discomfort. This gives us an opportunity to look at the way they're treating their discomfort and help to navigate to safer interventions. And so my final thing is to leave you with Margaret Mead's favorite phrase, or excuse me, famous phrase, which is, never doubt that a small group of committed citizens can change the world. Indeed, it's the only thing that ever has. Thank you so much for having me. My email is also going to be available to you. Feel free to reach out to me anytime, and I'll be sure to get back to you. Thanks again for letting me share.
Excellent. Thank you so much, Eric. I really appreciate how there's some themes that we're seeing between you and what Natalie's saying. So moving on to Dr. Karpman, unless we have any questions from the audience.
Okay. Hello, everyone. Thank you. I really appreciated Dr. Blackstock's presentation, and I very much appreciate Natalie and Eric's work with me, and appreciate them as colleagues and what they shared. I'm going to go a little bit fast through these because of time constraints. Next slide. I don't have any commercial support. As a physician, you have to disclose if you're getting money from pharmaceutical companies or vendors and so on. And I have no financial support. I'm going to take a really broad view of things, kind of an airplane or eagle's eye view down on the world, looking at biology, history, culture, strengths, and vulnerabilities, but also then zooming in for a little bit of a microscopic view of some things, or a cellular view. So going in and out. Next. I want to recognize that we are living on the land that is the ancestral homeland of the Coast Salish tribes, Lummi, Nooksack, Tupper, Skagit, Swinomish people. And I want to pay my respect to our resilient neighbors, fellow citizens, and community members. We'll go back one. Also, just to honor Billy Frank, who was a Nisqually tribal member who was very active in restoring tribal rights, treaty rights to fishing, and was arrested over 50 times, and ultimately resulted in the Bolt decision restoring Native tribes' rights to 50% of the fisheries. He then became a chairman of the Northwest Indian Fisheries Commission and worked for 30 years collaboratively with many other groups to fight for conservation and habitat protection. So as we've heard earlier from all the different presenters, life journey can be a struggle. And there's trauma of various sorts along the way, pain, sometimes anxiety and depression, and this can lead to hopelessness and despair, particularly when you've been the victim of genocide, when you've been forced to go to boarding school, when you've been forbidden from speaking your language, practicing your religion, when you've been cheated out of your land repeatedly and treaties are broken, or you've been enslaved and then had redlining, Jim Crow, and so on, as we talked about earlier. In contrast to these, we also find in life pleasure and delight. And we can find moments of calmness and tranquility and serenity, appreciating our family and our children, our parents, our loved ones, our faith. There's times of happiness and bliss, and times of hope and faith and joy. So these are contrasting. I'm contrasting these on purpose because they contrast with both trauma and they contrast with what happens to people when they suffer from addiction, a brain disease. So I think I'll skip this one because Dr. Blackstock did such a good job already talking about it. And only thing I want to say about ACEs or adverse childhood experiences is that the ACEs are very, ACE points for physical abuse, sexual abuse, and parental substance abuse are directly correlated with development of substance use disorder in future life, adult life. So let's talk briefly. I'm going to use opioids as my main example here, although we could also talk about alcohol, we could talk about tobacco, we could talk about other addictive substances. But opioids are really valuable for us in medicine as painkillers, and they allow us to do procedures that are very helpful, whether it be surgery. I worked in the emergency department for many years. I worked also as a family physician and delivered babies here in town. And so painkillers are very helpful in childbirth. They're helpful when we do painful procedures in the ER and the OR, and also in hospice. But when I was trained 30 years or more ago, there was little teaching about the mood altering effects of opioids, the fact that they can have antidepressant effects, they can give you energy, they can give you euphoria, and you develop tolerance to them over time and need larger and larger doses to get the same effect. Opioids in particular also are respiratory depressants, so people can accidentally overdose and simply stop breathing, and after you stop breathing for a certain number of minutes, typically 5 to 10 minutes, your heart stops. Now you're in full cardiac arrest and not breathing, and you die unless you get appropriate emergency care. This respiratory depressant effect with opioids is made worse by alcohol and benzodiazepines. So you get synergistic effects where somebody who might be using a particular dose of an opioid for pain, for instance, then drinks a bit too much, and that combination can kill them. Or, for instance, takes some benzodiazepines, such as a Xanax, Ativan, Klonopin, etc., for instance, to help them with sleep or with anxiety, and then they, again, don't wake up. Finally, opioids do cause physical dependence as well as psychological dependence. When people experience withdrawal symptoms that are severe, at least acutely, they have nausea, vomiting, diarrhea, loose flesh, restless legs, and insomnia. And many people who are opioid dependent find that they, even when they try and quit, by about the third day of physical withdrawal, they're so miserable that they go back and use because they recognize that that's the only thing to help feel better. Okay. So this is just a picture of the opium poppy. And if you look at the capsules down below, the seed pods, if you slice those with a razor blade or a knife and let the sap leak out and then collect that and scrape that together, you have opium, which was the first naturally occurring opioid that humans found. Next slide. When you take opium, you can extract morphine, and later we learned in the late 1800s how to make heroin from it. And the Bayer Corporation in Germany marketed heroin. It was considered to be a wonder drug in relieving pain and respiratory conditions, but then found to be very habit forming. And in the early 1900s, it was restricted. By then, though, the underworld, crime world, figured out that all these people who were dependent on morphine and heroin could be given illicit drugs. Next slide. So in more modern times, while I've been working here in Bellingham in the last 30 years, we had a lot of pressure as providers to treat pain more aggressively. The hospice movement was just getting going, and it was recognized that cancer pain was legitimately was being undertreated, and that we should be treating it more aggressively. But unfortunately, drug companies and marketing groups really pushed opiates and overemphasized their value and underemphasized the dangers of them. And I used to see a lot of patients who would use OxyContin, and they would come looking for drugs in my family practice in emergency medicine. An 80 milligram OxyContin was worth $80. And we used to see people commonly doing 2 or 3 of these a day. So with habits of $160 to $240 a day, they would snort these or sniff them or take them orally. Next slide. Currently, we've moved on to fentanyl. Now, in our community, there's a lot of illicit fake Percocet 30s, and they typically have an M on them for the company Mallinckrodt, one of the manufacturers, and they have an impress of a 30 on them, but they're not Percocets. And some people still buy them thinking that they are Percocets, and other people now recognize that they're actually fentanyl in them. But we've had a huge increase in overdose deaths, including young people, teenagers, who are trying these and dying because of respiratory depression. Next slide. So we've had really 3 waves, almost 3 tsunamis, if you want, of opioids in the United States. In the 1990s, we had a huge rise in prescription opioid overdose deaths. It's describing, as I spoke about, OxyContin is one of the more famous ones. We then recognized that, and prescribers began to prescribe less, and manufacturers came out with what they call abuse deterrent formulations of OxyContin that were harder to crush and snort and abuse. But there were already a lot of people already dependent or addicted to these opioids, and heroin moved in. Heroin was already here, but in lower numbers. Heroin moved in very cheap. So heroin was costing at that time around $25 a gram in our community, and it's now about $100 a gram. So it was kind of the classic thing of giving it away almost at very low prices, so that people who would previously have never even tried heroin, but were now dependent on prescription opioids, were willing to do heroin, and initially were smoking it or snorting it, and then later, as the price went up, found themselves shooting it because that's a more effective way to spend your dollars. And now, currently, we're in the midst of a fentanyl wave, and a lot of the heroin that's in our community is actually fentanyl, and again, it's the fentanyl pill. So next slide. So this is some folks in our community whose parents, these are people who died. We show a lot of graphs and slides, and I was fortunate that some of the parents of children who died have been willing to share the photos of their kids in hopes that they could help other families seek treatment and get help. The next slide. The DSM-5 criteria for mild, moderate, and severe substance use disorder are long, and I'm not going to go through all of them, but I picked out a few that I think are really important, and that is basically the difference between using or abusing things and actually being addicted. And the addiction part is using it despite the negative consequences that it has for you. And those negative consequences can include things like getting in trouble with the law, but also losing your job, dropping out of school, losing your relationship, your partner, if you're married or in a relationship, breaking up, having your parents and grandparents not trust you, losing your children, all these really huge losses that people have, and yet they still continue to use. Next slide. So I wanted to mention that addiction is a chronic relapsing brain disease, and there's a huge body of evidence around that, and I'll talk a little bit more about that today, but not too much. There are genetic environmental influences. One of the police officers I was working with as we were doing the naloxone training a few years ago to get all the first responders and law enforcement equipped with Narcan or naloxone, described it as genetics sometimes may load the gun, but environment pulls the trigger. So it's an interaction of them, and the ACEs studies that we talked about reflect that. So when we talk about trauma, we're talking about both emotional and physical pain, and we have a lot of patients with mental health disorders. We have really inadequate resources in our community for folks with mental health disorders. It's very hard to access care. We had aggressive promotion and marketing of painkillers, and then we also had inadequate training of medical providers. There was a lack of prescription drug monitoring. We fortunately lobbied hard with our state to get a prescription drug monitoring program, and all of you who have a license, all of you nurses, nurse practitioners, PAs, and physicians all have access to the Washington Prescription Drug Monitoring Program, and I encourage you to use it so you can tell whether people are doctor shopping and shopping around getting narcotics from multiple sources. There's also tremendous profit both in the legal and illegal marketing of these drugs. So next slide. This is just a demonstration that here in America, we have incarcerated more people than any other nation in the world. We had a drug war that started, as they show here, around 1980, and we've just had a huge increase in incarceration of people. Unfortunately, people of color are vastly overrepresented in this, much more likely to be arrested and sentenced. And we also have very poor resources in the jails and prisons for offering people good treatment, including medication for opioid use disorder. And we're fighting hard to get people that treatment if they are incarcerated. The next slide. This is just commenting that the calls for law and order were rampant. The next slide. And people of color were particularly targeted after long hundreds of years of slavery and then Jim Crow laws, redlining, mass incarceration. And we could have a Native American version of this showing what's happened across our nation with genocide, with people losing their land, with being given reservations that were then drastically reduced, and then losing their treaty rights and not getting the medical care and other things that were occurred. There's also what's called the Termination Act, the Dawes Act, a lot of history there that I'm not going to go into here, but we have in our community a significant Native American population that has suffered mightily. Next slide. So, and I'll go to the next slide too, in the interest of time. And this is just again showing that we're talking about real people here and not just statistics. This is just a brief kind of idea about the natural history of opioid dependence. Many people may not be even feeling normal when they first use opioids, but if they were feeling normal, they get euphoria, they get a kick from the opioids that they may be getting prescribed for a perfectly legitimate reason, a painful condition such as an accident, a car accident, a fall, skiing, whatever. After a while, the euphoria begins to lapse, and you find yourself in withdrawal. And despite using the opioids, you don't ever get back to the same high, but you start to get sicker and sicker when you're not getting it. And just getting back to feeling normal the way you were in the very beginning before you ever took any opioids is difficult to achieve. Next. So this is again the addiction downward spiral. People, let's just start with say binging and intoxication here. Somebody gets high and then they go into withdrawal and then they don't want to use again. So they end up thinking about using and they develop a preoccupation or anticipation for the next time they're going to use. So let's say it was a weekend user and they're all week long, they're thinking about the next weekend. What happens over time is people develop more and more tolerance, they need more and more of the drug. The withdrawal symptoms become more and more severe. It begins to impact their social, occupational, recreational activities, and they have spiraling distress. So that's kind of the definition of addiction. This is again a cycle that we see that we try and break, help people break as they try and get into recovery and get their lives back if they ever had a life. This is just to say that there's a lot known about the brain and the neurocircuitry, the neurobiology of this. Some of the same areas that are impacted by trauma are these similar areas that are impacted by drug addiction. And so I'm just going to point out the nucleus accumbens is an area that's involved with motivation and reward. Some people call it the reward center. It's associated with pleasure and reinforcement. It's heavily involved with addiction. The amygdala is another area that's associated with fear and anxiety and aggression. And these are deep structures that have been present in animals and in evolution for a long time. And then there's the prefrontal cortex, which you see over in the front there, which is kind of our override center where we actually have a will to live and have our personality and some of our executive function, some of our ability to make good choices and balance conflicting thoughts and determine good and bad. In this area becomes overcome. Next slide. This is another slide. I'm going to skip these because of the interest of time, and I'll skip this one too. And even this one we'll skip and go to the next one. I already spoke briefly to the neurobiology of trauma, and I think I'm looking at the clock. I'm going to skip this. Let me stop here and say that this is kind of demonstrating those areas that I was talking about in the brain. On the left, you see that we have the control from the prefrontal area telling us, don't go, do go, for instance, don't pick up that needle and chew heroin. And the saliency is the importance. And then there's the memory section. So if you go over to the addicted brain, what happens, unfortunately, with addiction is the control center is diminished. It's not gone completely. Your free will's not gone completely, but it becomes like the good angel on one shoulder and the devil on your other shoulder becomes much bigger. The saliency, the importance of the drug, and the memory of how good it felt becomes bigger and bigger. If people get involved in compulsive behavior, I think the next slide may be helpful. It's pretty much the same thing here, except that there's some PET scanning here showing you the brain, not addicted brain and the addicted brain. You can actually see with these imaging studies the areas of the brain lighting up or diminishing with this phenomenon. So this is an important slide about medication for opiate use disorder or medication-assisted treatment. If you look at the green bar, this is the average population. So if you think of your friends in high school, this is just the general group of people. And then if you have some friends who became addicted to, for instance, opiates, they would be the red bar. They have a 6-fold higher likelihood of dying as a result of their addiction. If you are able to help them get treatment, and that treatment does include medication-assisted treatment, if it does include medication-assisted treatment, their risk of dying decreases more than 4-fold. It still is greater than the general population. It's in the 1 to 2 times the general population. So they're still much more likely to die than if they never become addicted, but their chance of dying is markedly decreased. If this was cancer care and we had a treatment that would reduce the risk of dying from cancer 4-fold, that would be a huge moneymaker. Next slide. So I wanted to point out that medications for opioid use disorder are standard treatment. A medical letter is a medical version of Consumer Reports. It's a non-biased review of different medications. You can look up medications for asthma or seizure disorder or diabetes or hypertension, and it'll give you a good balanced view of what are the recommended medications and a stepped approach to treatment. And it includes these medications for opioid use disorder, which are really mainline therapy. Next slide. This is briefly just to say that all of us have endogenous opioids in our bodies. We make opioids ourselves. We have mu opioid receptors, and morphine activates that receptor. And again, if you take a lot of it, you can get a lot of pain relief. You can also get a lot of euphoria, and you can stop breathing and die. The medication buprenorphine you can use for opioid use disorder is only a partial agonist. It only partially activates that receptor, and also does not cause the respiratory depression that you see with other opiates. So it's a much safer medication. Then we have naloxone, which fortunately is a complete blocker. And we can use that to help save someone's life or treat them when we've given them a little bit too much morphine, for instance, in the post-operative area. Next slide. Next slide. I'm going to jet because I'm looking at the clock. I want to respect your time. The 4 drugs that are common for opioid use disorder include naltrexone, which we also use for alcohol use disorder. Comes in a pill or an injectable. Monobuprenorphine we use in pregnancy, and the combination product of naloxone, medication we use to revive people who've overdosed, mixed with buprenorphine, is a potent medication that was marketed under a brand name Suboxone. It is now available generic also. And then methadone, which is only used in federally and state certified opiate treatment programs. It's different than the methadone that's prescribed for pain. You're not allowed to treat addiction with methadone in the doctor's office. And then naloxone, which is also known as Narcan nasal spray or injectable. We also use counseling in a huge way in treatment of addiction, and we do have accountability. You wouldn't treat someone's diabetes without monitoring their blood sugar. And we don't treat addiction or opiate use disorder without having some accountability and doing urine drug testing. Next slide. I'm going to skip this in the interest of time again. So let's talk briefly about greedy big profits. Next slide. This is El Chapo, who was the head of a Mexican drug cartel, who was arrested and made some very famous escapes multiple times, and a lot of drama around that. Next slide. This is a Chinese official 150 years ago. Next slide. The Chinese emperor forbid the importation of opium into China in the interest of protecting Chinese people. There were some corrupt officials at the port of Canton that allowed the British to import opium and sell it to smugglers. And that prior official was an honorable official who followed the emperor's direction. They arrested the British captain and his sailors and confiscated all his opium and destroyed it, and threatened them with death if they did it again. The British Navy then, with the support of with the pressure from British merchants, shelled the Chinese coast for a year, and ultimately, with their superior weaponry, they were able to beat the Chinese back and confiscate some Chinese property, which is now called Hong Kong, and were allowed to continue to import opium, which they brought from India and Bengal into China in order to have free trade and also to restore the debt that Europe had acquired with China, because Europe was buying a lot of tea, porcelain, and silk, and silver was accumulated in Canton, and the opium importation by the British allowed them to restore a balance of trade. So it sounds a little bit deja vu of some of the trade wars we've had recently. Next slide. Purdue Pharmaceutical Company was the maker of OxyContin, and is now about to go out of business and declare bankruptcy and have to pay a lot of money. But the family that owned Purdue has moved billions of dollars that they made off seeds and protected. Next slide. So, and these other companies that are marketers and middle-level providers of drugs also profited immensely from the illicit opioid trade. So next slide. I guess I'll go back and just mention that what I'm trying to say here is that the profiteering from taking advantage of the biology of human beings and the suffering that people have in the way that drugs such as opioids work, the profiteering knows no bounds. It knows no national bounds or races. So you have to be careful about who you demonize as the bad guys. There seems to be plenty of blame to go around, and lots of people taking advantage of this. I just was going to talk again about Chief Joseph as an example. If you look up and read a little bit about Chief Joseph and the 700 tribal members, men, women, and children that fled the U.S. military as they fled from Oregon towards Canada, and ultimately lost their land, freedom, so on. It's a heartbreaking story. Next, and last is just to honor some of my colleagues at the Lummi treatment program that I also work at, who are working hard to maintain pride and traditions and cultural values. That's all I have. I'm looking at the clock. It's time to end. Thank you. This is just some other information that if you want to look up more about this, it's available. Thank you.
Excellent, excellent presentations. I know I've learned a lot from our speakers, and they do inspiring work. They come alongside some of the most vulnerable people in our communities. They work to relieve human suffering with non-judgmental and an evidence-based approach. So thanks again to the team from Cascade Medical Advantage, to Natalie, Eric, and Dr. Cartman. Thanks so much for the work you do in our community too. Thanks to everybody who came to join us today, both live and watching the recording later, and for taking some time to learn new ways to care for people who are hurting and who need our help. Thanks, and have a good rest of your night.